aware of the hazards from musculoskeletal to radiological to needle stick injuries that healthcare workers are exposed to within the hospital environment. She then decided to pursue postgraduate education in order to focus on learning more about occupational exposures within the healthcare work environment and to contribute to finding ways of minimizing these. In 2006, Ms. Gamontle was awarded the U.S. Fulbright Scholarship, which enabled her to study for an MPH degree with a focus on occupational and environmental health with the University of Arizona in U.S. Following her MPH, she went back to Botswana where she worked for the Ministry of Health as a senior health officer in the Environmental and Occupational Department. Her current research is on Mycobacterium Tuberculosis, TB, among healthcare workers. Aligns with one of the objectives of the Ministry of Health, that of finding ways of reducing TB in Botswana. After completing her PhD, she plans to work together with a hospital which gave her the opportunity to conduct research to find ways of translating her findings into practice. So can we please all put our hands together to welcome Ms. Gamontle.
Thank you, Tina. Remind me to pay you for that afterwards. Thank you. I'll get started. My name is Bojosi, as Tina said. Today I'll be presenting part of the findings from my PhD work. So the title of my research is Perspectives of Botswana Health Policymakers and Healthcare Workers Towards Mycobacterium Tuberculosis Infection Control and Occupational Health Policies and Guidelines. Can everyone hear me? Okay? Okay. All right, so in terms of the outline of what we'll be talking about today, first I'll give you a scope of the, and go a little bit into the background and research questions, and then I'll talk a little bit about methodology that we use for our data collection, and go a little bit into some of the findings that we have, and eventually we'll get to the questions. All right, so Mycobacterium tuberculosis, commonly known as TB, and I should mention here that we're actually talking about pulmonary TB. That infection and disease results in over 2 million deaths per year worldwide. And 90% of those are actually in lower and middle income countries. If you see here, this map, the darkest green represents where there's a highest incidence rate of TB disease. Now, if you look at where the arrow is, the red arrow is, that's Botswana, and there was, in 2009, according to WHO, 478 cases of TB per 100,000 general population. So to give you an idea of what that means, if you compare it to Canada, in Canada we have, this is around 2011, 4.7 cases per 100,000, which is a magnitude of 100 times less than what you see in Botswana. So that's that's the scope of the problem. Now, as a way of background, we know as a scientific community that in the 50s and 60s we had found ways of controlling and preventing TB in the general population. Now, what happened is, in the 1980s, with the advent of HIV/AIDS, we saw the rise again of tuberculosis. And what happened for healthcare workers who are in front of taking care of patients, there was a rise of TB, particularly among the healthcare workers. And we found this was demonstrated, the link between patients who have TB and healthcare workers who provide care, who actually are exposed, and some of them who got TB were demonstrated through molecular techniques, and this is how we understood that TB was an occupational disease. Now, what happened particularly in high-income countries like the US, for instance, they found ways of making sure that healthcare workers are, there's control measures that are implemented so that healthcare workers are not exposed to TB, or their exposure is minimized. Now, what happened in the least developing, in the developing countries or low and middle income countries, is that because of low resources and the fact that healthcare systems got weakened by HIV, there wasn't really resources that were put into place to reduce exposures for healthcare workers. So, which meant that healthcare workers in developing countries in particular had high, and still have high TB disease compared to the general population. Now, given that some of these examples, some examples of high TB incidence among healthcare workers are found in countries like Malawi and South Africa, where the studies have been done to see how many healthcare workers, to see what the TB disease among healthcare workers. Now, given this narrative, what we wanted to find was, beyond the incidence rate of healthcare workers having higher TB disease compared to the general population, we wanted to understand what is the narrative that healthcare workers are talking amongst themselves in terms of exposure to TB and in terms of implementing control measures that are in place. And we took Botswana as an example for this. So our research questions were, what are the perspectives of policymakers and hospital leaders towards the formulation and monitoring of infection control and occupational health policies and guidelines used in the prevention of occupational TB? The second one, what are the perspectives and attitudes of healthcare workers who have direct contact with TB patients towards the process of implementing guidelines used in preventing exposure to occupational TB? And finally, what is the content and quality of the infection control and occupational health policies and guidelines used in the control of TB in healthcare workers? And we used, for this particular question, we used a standardized tool, which is in fact comes from Canada, called Appraisal of Guidelines for Research and Evaluation, or the AGREE instrument for short. Right, so a little bit about our methods. The data collection happened a while ago. Data collection happened in Botswana between March 2012 and November 2012, and we had 3 hospitals. 2 of those were public hospitals, and 1 was a private hospital, and we had a health administration center, which is in fact the Ministry of Health itself. We conducted 21 interviews and 5 focus groups. And then we collected some guidelines from hospital leaders and policymakers in order to evaluate those. Who did we interview? We interviewed hospital leaders, matrons, we interviewed TB policymakers, TB coordinators, infection control leaders, and occupational health personnel. And for the focus groups we held with frontline healthcare workers or hospital workers. Examples of these were hospital cleaners, drivers, auxiliary nurses, even nurses and laboratory technicians and radiographers and people like that. In fact, all of the interviews were conducted in English, and then the focus groups, some of them, for homogeneity, the focus groups were divided into, the health professionals were grouped into one group, and then the hospital cleaners and the drivers were grouped into one group. So for the hospital cleaners, we held those focus groups purely in Tswana, which is my native language, in fact. We used a methodology called Interpretive Description, and I'm going to go a little bit into what Interpretive Description is. And knowing that this is here in SPPH, we're mostly coming from a background of quantitative studies, I'm going to talk a little bit, very briefly, about qualitative work. Okay, so the background here is that, I don't know how many people know any methodologies from qualitative studies? Okay, all right, a few. Okay, so the background is there are methodologies that come from sociology, from philosophy, from anthropology. These are the traditional qualitative methods: ethnography, grounded theory, and phenomenology. And all of them are mostly using what is called, or seeking to find what is called somebody's lived experience. So this is when you ask participants their views rather than studying from externally, basically. And all these traditional methods move from you generate data and you move to producing your theory, or you're creating theory from data. Now what happened was health researchers began to notice that they could improve their health outcomes for their patients by asking patients about their own diseases, right? So they realized that qualitative methodologies could provide that for their patients. So they began to use some of these traditional methods, ethnography, grounded theory, and phenomenology. So then what happened was they found that some of these methods are purely theoretical. They're purely for theory generation, and they were not necessarily availing themselves to be used in the applied health sciences arena. So this is when some of the health researchers, in particular the nursing field, began to come up with methodologies that would be appropriate to be used in the health research. And one of those methodologies is interpretive description. Interpretive description is a qualitative methodology that actually is a brainchild of Professor Thorne, who is a professor in the School of Nursing here at UBC. As a way of foundation, it has similar roots as grounded theory and ethnography and other inductive methodologies. But what differentiates interpretive description from traditional methodologies is that it lends itself to be used in the applied health sciences. So instead of theory generation, you can generate themes and categories that can be applied in a clinical setting or in a healthcare setting environment. So a product of interpretive description gives you a coherent and conceptual description of patterns and commonalities and variations in themes that can eventually be put to use in a clinical setting. For our studies, this is what we use. For our study, this is what we use. We use interpretive description, and for those who have done qualitative work, they know the volume of data that comes from that is voluminous. So what we did was we used NVivo, which is a software for data management and for organizing all the files that we had. I mean, one interview, which is 1 hour, 30 minutes, can generate 20 to 30 pages. So we used NVivo to manage that. Okay, so how did we do the analysis for interpretive description? There are Thorne talks about generally 4 stages that happen in interpretive description, in analysis of data and interpretive description. There's comprehension, there's synthesis, and then theorizing, and then recontextualizing. So in the comprehension stage, this is where we went into the data, and then also the environment, the social context that we were researching in, to understand the participants themselves and to understand the social environment from which the participants come from. And then after all the transcripts were transcribed and translated, which were in Tswana translated to English, we did what is called immersion. This is when you read the data, you read all of the transcripts that you have, and you, by then, withholding judgment, without saying this is what just reading the whole thing. And then from there, we began what is called open coding. And during open coding, this is when you pick a phrase either from the data itself or externally, and code pieces or chunks of data with a similar code. And from there then, constant comparison analysis is when if you have an interview, for instance, if you have an interview, a transcript that has an interview, and different pieces of data are labeled or coded with one code, what you do then is go through each of the chunks that you have, chunks of data that you have, and ask yourself, what is different about text or chunks of data that are coded with the same code? What is different among them? What am I beginning to see here? So those are some of the things that we did. And then theorizing, of course, which is where you come up with best guesses of what you're seeing in the data. And then going back to the environment from which the research came from to recontextualize or to use what you found in that clinical setting. Now, what I want to emphasize here is that keep in mind that the actual, even though it may seem like it's a linear process, you can move from open coding to categorizing to making themes back and forth until you reach what is called saturation. Okay. And saturation is a process where there's no longer new information that you're seeing or new variations, new variabilities that you're seeing at that point. Okay, so we're going to get into findings. I'm not going to present everything that we found today because it's a lot. But what I wanted to emphasize here is that what we're talking about next is, in fact, a synthesis of the perspectives of the participants. From the data, we came up with 4 categories, and each with major themes. The categories that we had were guidelines, occupational health services, infection control, and barriers to guideline implementation. And I will not be going through all the categories today. I'll just pick a few to give you an example of what we came up with. So, for instance, the occupational health themes. Under the occupational health categories, we had some of these themes. And some of these themes are limited or no occupational health services in hospitals, or no evidence of occupational TB exposure for healthcare workers. And we'll get more into detail about what this means. But before that, I wanted to give you an overview of a historical point of view of occupational health in Botswana. Then this in fact came from the data itself. We compiled this diagram from the data that we got from the participants. So historically, there are legal instruments that are used to govern workplaces, such as the Factories Act of 1973, Mines, Quarries, Works and Machinery Act, agrochemicals, etc. Now, what I wanted to emphasize here is that most of these instruments, in fact, focus only on the work environment that the Act is about. So there's actually very few, at this point there's no Act that focuses on healthcare workers. For instance, the Factories Act focused on factory workers and the Factory Environment, Agrochemicals Act, etc. The Public Health Act itself of 1981 also does not necessarily focus on, there's no section that focuses on healthcare workers. It focuses on public health in general. Now, the act that sort of included healthcare workers is the Radiation Protection Act, but that focuses on radiological exposures. And the one thing that I wanted to bring your attention here is that there was actually, up until 2004, there was no mention of an occupational health and safety policy. But what happened is in 2004, the Ministry of Health, the Environmental and Occupational Health Division, which is actually the department that I worked in, but after this, came together with the Occupational Health and Safety Division from the Ministry of Labor within Botswana. And they came together to put together an occupational health and safety policy. But what happened was there was a bit of a conflict with the Ministry of Health saying, no, we're the health people, we understand what happens with exposures, with health issues, so leave the policy to us to host. And the Ministry of Labor was saying, no, but we are the Ministry of Labor, we understand the workplace, we understand the work setting, we understand exposures that happen in workplaces, so leave the policy to us. So that kind of friction happened, and eventually the policy was not drafted. So everybody just washed their hands off and left that. It wasn't until 2012, which is when I was actually doing the data collection, that the Ministry of Labor and Home Affairs was now drafting the policy itself. The Ministry of Health had said, okay, you can go ahead and do that. So that's just to give you an overview of what's happening in Botswana in terms of occupational health and safety. So, I mean, this was back in 2012, so we don't know where the policy is, but that's how things were back then. Okay, so back to the themes now. Under occupational health services category, we had the theme of limited or no occupational health services in hospitals. Under this, we found that the government doesn't or didn't have it wasn't enacted, it was a draft at this stage, no occupational health and safety policy. There was also no occupational health committees or offices in the different hospitals that we researched in. Only one facility out of all the facilities that we researched in had an occupational health committee chairperson and a committee, and we got to interview this person. There was no healthcare worker TB surveillance program in the country. They've spoken about it, but it's not implemented. There was inconsistency of availability of personal protective equipment such as the N95. In some hospitals you'll find, in fact in all the hospitals, apart from the private, public hospitals, the provision of the personal protective equipment in terms of N95 was only restricted to high-risk areas. What was called high-risk areas? These are medical wards and accident and emergency where there's an influx of patients. The central medical stores, which is a place where all the personal protective equipment and supplies, medical supplies come from, sometimes had issues supplying the personal protective equipment for healthcare workers. So you would have a duration where there was no N95s, and healthcare workers had to take care of TB patients without them. There was also what we found, a disparity in compensation of occupational diseases. An example of this was, from Botswana, there are some workers who are not workers who work in South Africa. And some of them, when they come back, you find that due to the occupational exposures they had in the mines, they had developed TB and sometimes silicosis. And these workers were compensated by Botswana government, but in terms of TB, the healthcare workers within Botswana itself were not compensated. And we'll talk a little bit about that in the next theme. There was also under this theme, the perception that infection prevention and control does everything that occupational health would do. So why would you need occupational health? But then there was a variation in this, because even though people seem to believe that you don't need occupational health, there was an agreement that you in fact need occupational health within the hospital environment. So for the second theme then, which is no evidence of occupational TB exposure for healthcare workers, the participants were saying majority of the in-depth of the hospital leaders and the matrons and the high-ranking officials believe that there's no evidence of healthcare worker TB exposure. They believe that there's no evidence that healthcare workers are exposed in the workplace. They were saying because there's a high rate of HIV in the country and high rate of TB in the community, it could be that the healthcare workers were exposed in the community, so there's no evidence that they were exposed in the workplace. But there was also TB coordinators, for instance, understood, and they had that information that there were some healthcare workers who were working in areas where high-risk areas get identified, but then later developed TB, and some of these healthcare workers were HIV negative. So there was that knowledge, even though they were saying there's no evidence. As far as private hospitals concerned, they actually had fewer TB patients, so they really found no pressure to begin healthcare worker infection prevention control or occupational health, or even to begin to collect data towards identifying exposures in healthcare workers. There was also that we found that no national system to record or analyze present TB data by occupational title. So the Botswana National TB Program, which is a national program, a national registry for all TB patients in the country, collects all this data, but if you look at the forms, the system doesn't actually, there's no way of knowing what this person, even though they have TB, what their work is. So there's no way of knowing who's a healthcare worker and who isn't in that system. So next I'm going to show you one of the codes of the people who believe that there's no evidence of occupational TB exposure for healthcare workers. So here she basically says, if the healthcare workers have no proof, no evidence that they're exposed in the workplace, they're exposed in the hospital, they don't have leverage to fight against the government in terms of being given compensation. So that's basically the essence of this code. Now the next theme, infection prevention and control, next category. So we had a couple of themes under this one, but three of them: awareness of acknowledgement of importance of IPC, hospital physical structures not conducive to IPC, and some infection prevention control measures implemented. So I'll pick one or two and get into details about this. So hospital physical structures not conducive to infection prevention and control. So in this we found that the healthcare workers are saying there are no dedicated TB isolation facilities in 2 of the 3 hospitals. And the reason for that is that during the advent of HIV, pre-HIV era, all the hospitals had TB isolation wards where they put all TB patients in. Now, what happened was after the HIV scourge happened, all the facilities that were used for TB were then given to accommodate and hospitalize HIV patients who needed hospitalization. So which meant most government hospitals were then left with no TB isolation wards. And the thing to note here or add is that TB is in fact an opportunistic infection for most HIV patients. So you find that in Botswana, for instance, 70% of people who have TB are also HIV positive. Right? And another thing was that for newly built hospital structures, even then there was little consideration for IPC. For the few departments within the hospitals who had equipment such as biosafety cabinets and anything that were used in control measures for TB, maintenance was really badly done, poorly done. Some buildings, for instance, had no windows and therefore no natural ventilation flowing into the patient's areas. And what I wanted to note here is that most hospitals don't have, like here in Canada, we find that is that all the rooms are negatively pressurized for TB, if there are any TB patients. There are all those infection prevention control measures in place. Now here, because of lack of resources, what was mostly used is that to open windows to allow natural ventilation in, to dilute, dilution ventilation, basically to reduce TB concentration in the rooms. And for those for buildings with no windows and therefore no natural ventilation, etc. So then, and finally here, referral departments were unable to perform IPC practices due to spatial challenges, as I mentioned. Okay, so the final one is barriers of implementation. Under this one too, we had a couple of themes. Healthcare worker related factors. The perception among the participants was that healthcare workers do not do their job as they ought to do. One of them even mentioned that it is human nature not to want to follow procedure. So this is some of the things that the participants said. One thing also was that the participants were saying IPC is not taken seriously. Right? Perception among some healthcare workers was, look, we're already exposed, so why should we protect them? Why should we protect ourselves against TB? Because we're already exposed. IPC also was not a top priority for healthcare workers. An example of this, somebody gave an example that if you're a nurse and you're having 76 patients, for instance, he gave this example, 76 patients, and you're running around and there's only 2 nurses in the whole ward, IPC is not going to be your priority at this stage. There was also poor attitude toward infection prevention control measures. Participants were saying, we were able to take care of patients in the past without all these gadgets, so why should we use them now? There was a perception also that healthcare workers have IPC knowledge. It is the implementation part that is lacking. But there was also variability regarding this perspective. Some saying, no, there's healthcare workers actually don't know that they're exposed. Even if they know, they don't know what to do. And the fourth one here, the fourth theme in this barriers to implementation was institutional or systematic barriers. So for this, participants were saying there's lack of communication between healthcare workers, implementers, and policymakers, leadership, and the workers. Some of the workers felt that there were events that are going on within the hospitals and they were not notified of these. There was also limited resources, shortage of healthcare workers, as I mentioned before. Somebody gave an example that if you have 76 patients and there's only 2 healthcare workers, you're not going to pay attention to wanting to prevent yourself from being exposed to TB. An example of limited resources, again, lack of PPE, lack of N95, which was only distributed to areas labeled high risk. There was also no separation of funds to train healthcare workers in terms of TB exposure and preventing TB in healthcare workers. Some of the training that went on was funded by external organizations, some from the US, which came in to train for capacity building for healthcare workers. But apart from that, the government itself really didn't have any funding that was solely for training healthcare workers in TB exposure and prevention. Now, one of the things about interpretive description is conceptualization, as I mentioned before. And one of the concepts that came out of this is what we call armoring. And this term comes from Tswana. This is what the participants were saying. Hui papana translates to armoring. And armoring is a Tswana phrase which is commonly used in the context of military to mean that soldiers are fully prepared for war. They're fully geared for war. So the participants in the focus groups, these were your drivers and hospital cleaners, were saying professional healthcare workers, for instance, nurses or doctors, would come into the ward or cubicle wearing N95, wearing gloves and goggles and coats and everything, all personal protective equipment, basically, to provide patient care for a particular patient. And in that same instance, you'd find that a cleaner or a driver who is also assisting the patient by giving patient care does not know that the patient has an infectious disease to begin with. And in addition to that, they themselves are not protected. So these are some of the things that they were saying. So then in conclusion, those are some of the interviews that we held and some of the information, data that came out of the interviews and focus groups. And what we're going to do now is, I didn't want to talk about the AGREE tool and evaluation of guidelines today because that'll be a bit too much. So what we're going to do now is to bring all the information, all the data, all the concepts that came from interviews and focus groups, and the outcomes from the AGREE tool, how we evaluate the guidelines, and bring that into a model by Walt Gibson. And this model allows one to look at the data, looking at the context, the socio-economic and political context of the country from which the data came from. And then we'll finally from that have findings and key assertions and thematic descriptions, and eventually we'll come up with recommendations based on the literature of what people around the world have done, evidence-based. And then eventually knowledge translation, where we'll go back to Botswana and present to all the research sites that we were collecting data from and share with them our findings and recommendations. I'd like at this stage to acknowledge my supervisor, Professor Karen Bartlett, whose support is immeasurable, and all the healthcare workers who participated in in-depth interviews and our focus groups, and the matrons and other hospital leaders. These are people who took it upon themselves to look for the participants who took part in our study. And my research committee, and finally my research assistant who helped transcribing and translating some of our transcripts. And we'll take questions at this stage.
Thank you, Ms. Gamontle. We're now open to questions.
Yeah, that was a lovely presentation. I'd like to know if you think the results would have changed much if more hospitals had been engaged. You only engaged 3 hospitals?
3 hospitals and a health administration. I can't say I know for sure, but what I know is that the hospitals that took part in our study, one of them is the biggest tertiary hospital in the country. So I would imagine that if what we found happened in that particular hospital, that is probably happening in other hospitals or even worse. Because they, compared to other hospitals and clinics, they have more resources and they have specialized care and they have specialists. So, yeah.
Hi. I recognize that qualitative research is an objective methodology to assess subjective measures. I was just wondering, with your thematic analysis, did you have any other researchers who worked along the thematic analysis with you to check and validate, I suppose, the themes, or is there any other validation measures that you did for the research?
Yeah, so what I'm hearing you asking about is the trustworthiness, this a term of used in qualitative methodology, which means how is what you've done trustworthy? And it's a valid question. So what I had wanted to do at the beginning of my coding is to give another person a text. This is one way of checking if what you're doing is trustworthy. Give them the codes that you have, that you've developed from the text, and give them the criteria, because as you're developing codes, you develop criteria for what is included under those codes. Give them the criteria, give them the same text that you've coded without your codes, and then let them code. And what happens is there can be differences or there can be similarities in the way you code, and that is how you assess your trustworthiness. Yeah. Not yet. Yeah. But it's something that doesn't break or make anything. It's the way that interpretive description is. Professor Thorne, what she emphasizes is that the way traditional methodologies do it is you have a checklist. For instance, grounded theory. You have a checklist of all the things that you need to do for you to call your methodology grounded theory. And if you don't have it, then you've done something else, what is called method blaring. But what Professor Thorne says is that the way she created interpretive description is that if you're able to account for everything that you have done in your work, that is trustworthy enough.
Thanks, Bojosi. We have an online question I'm not sure you're going to be able to answer, but it's, did cleaners have a higher rate of TB infection than the healthcare workers?
Yes, they did. How did she know or he know?
This is Peter Griffin asking, and I'm not sure how he knew. But there you go, there's the answer. Can you go back to your original slide with the map on it that showed TB incidence globally? So incidence is actually a little lower in Botswana than some of the surrounding countries. I'm wondering, do you have any insight? Say you were to go to South Africa and repeat this.
Yeah.
How do you think things would come out differently? Do you think it would look the same? I'm just curious if you know anything about the sort of differences between the countries in terms of how they're coping with these things.
Yeah, I mean, South Africa, the example that you gave, actually has the highest HIV incidence in the continent, one of the highest, if not the highest. Now, as I mentioned before, TB is an opportunistic infection for HIV. So it is likely that countries where there's a high rate of HIV, there's a high rate of TB. And in fact, in South Africa, some years ago, there was an outbreak of not just TB, but multi-drug resistant TB and extreme drug resistant TB. So I would imagine that their rates would be higher.
Do you think if you were to repeat the study in South Africa, you would see the same sorts of themes that you found in Botswana, or? It's a slightly different social context, that's all. I'm just wondering if you would find the same thing, or?
Yeah, I mean, I'll give you this example. There's a study that was conducted in Malawi, which looked at incidence rates for healthcare workers, and they found that within that period of time, the incidence rates for healthcare workers were higher than in the general population, which is not surprising. But what they also found was that the guidelines, even though there were guidelines, they were not implemented the way they could ideally be. So that is one of the similarities between that and what we found in our study. Some people will say, we don't even know where the guidelines are. They're like, what guidelines? So I think there would be some similarities.
Would you be able to compare the health system then of South Africa in comparison to Malawi? Which one would you consider more robust?
I think in terms of systems, South Africa is probably better compared to a lot of African countries in terms of the capacity they have in their hospitals and the capacity they have for in terms of the number of healthcare workers. So I would imagine that South Africa is, but I mean, I would not be able to say because I haven't studied the two systems, but I would imagine that South Africa would probably be a little more different or have a little more capacity compared to Malawi.
Thanks, Bojosi. I'm just curious, in one slide, you said some of the interviews were done in both English and Botswana. Do you mean like some interviews, are they from the same individual but in both, like same content but in different languages, or some people in English, some in Botswana? Or I'm just curious how the language plays into the comprehension or like the theme generating.
Yeah. So when I started the interviews, what I would tell someone, the participant, is you can speak English or Botswana. I'm fluent with any, so whichever you choose. And I told them, because there are other languages in Botswana, I said, if you don't speak any of those two languages, you can speak whatever language, you'll find a translator for you. So some interviews, the in-depth interviews in particular, were mostly in English. But here and there, somebody, a participant would throw in a Botswana word, which is basically what we all do in Botswana. We journalize English. But they were mostly in English. The focus groups, however, the focus groups with the professionals were all in English, and then with the drivers and hospital cleaners, those were in Tswana. And the thing to add here is that it's not even, some of these people were older people, older than the average worker, I should say, put that into context. So the Tswana that they spoke is not even spoken by younger people. Like if you talk to a young person in that language, they will not understand. You know, yeah, like this term "hui papana," young people would not understand what that means.